Hello, everyone, and welcome to Arthritis Talks, Medical Cannabis, What's New and Changing. I'm Dr. Sean Bevan, Chief Science Officer at Arthritis Society Canada. Thank you for joining us tonight. While we have come together for this event from many different places, I would like to acknowledge the land on which I am located on and which our Toronto office stands is the traditional territories of the Mississauga of the Credit First Nation, Anishinaabeg, Huron-Wendat, and Haudenosaunee Indigenous peoples. Today, this meeting place is home to many First Nations, Inuit, and Métis peoples, and I am grateful to have the opportunity to live and work on this land. Cannabis for medical purposes has been legal in Canada for more than 20 years, but there are still so many questions surrounding it. In fact, one of the most common reasons why people reach out to Arthritis Society Canada is because they have questions about medical cannabis and arthritis. Today, we are very fortunate to be joined by Dr. Jason Busse, a medical cannabis researcher and expert from McMaster University, who is here to talk to us about what's new and changing in the medical cannabis field. Before we get started, a few logistics. This webinar is best viewed on a laptop or desktop computer. If you have technical difficulties, please email arthritistalks@arthritis.ca for assistance. If you have a question for our presenter, you could submit it through the Q&A button at the bottom middle of the screen, and we will try to get to as many questions as possible during the hour that we have together. You can click on the chat icon in the bottom middle of the screen to access the chat and connect with other participants and Arthritis Society Canada's chat moderator. If that's distracting and you'd like to close the chat completely, please click the red X icon to close out of the window. We are pleased to continue to provide captioning of our webinars to accommodate the diverse needs of our audience, and you'll see that running along the bottom of the page. So many questions we received in advance followed similar themes, so we will go through those first before going into a live Q&A at the end of the session. And before we get started, I want to thank our event partners, Pfizer, United Way Winnipeg, and other partners for their financial support of our Arthritis Talk series. Now, let's get started, and a warm welcome to today's expert, Dr. Jason Busse, who is joining us from Ontario. Dr. Busse, what new information and research is emerging about medical cannabis for people affected by arthritis?
Yes, so great question, of course, and thanks so much for the invitation to be here tonight. So we do have information that we can present to help inform some of these questions. As you mentioned, cannabis has been legal for select medical conditions since 2001 in Canada, and licensed healthcare providers can provide authorization for patients to acquire cannabis for medical purposes. Now, just to give you a sense of the interest in this therapeutic option, the number of Canadians that Health Canada has captured in terms of who's been authorized to use medical cannabis has increased from about 24,000 in 2015 to about 377,000 by September 2020. So there's been quite a dramatic increase in the use of these products. Now, there was a survey that was done. This was in the United States, but I think the results are probably generalizable to a lot of Canadians as well. And they were curious when they asked people from the general population what their beliefs were around benefits and harms of cannabis use. Interestingly enough, they found that 81% believed that cannabis had health benefits. So a very strong majority were enthusiastic. 9% believed it had no risks whatsoever. And interestingly enough, about 1 in 4 believed that cannabis was not addictive. Now, in reality, we have evidence of benefits in some conditions. We don't have as much evidence as we would like. Cannabis does have risks, of course, and it can be addictive. So what we learned from this survey is there's a bit of a enthusiasm for medical cannabis that is a little bit inconsistent with some of the evidence that we have out there. Now, in terms of where people might be getting their enthusiasm, the internet has a lot of information on medical cannabis. This is a site I simply found at random. There's nothing particular about it. This is a healthcare provider in the US that indicates on their website they've spent a lot of time collecting information on conditions for which cannabis has been demonstrated to be effective. And here is part of that list. So we have everything from genital herpes to different types of cancers to diabetes. We also have writer's cramp. We have psychogenic disorders. We have stuttering, anorexia nervosa, Bell's palsy, carpal tunnel syndrome, gastritis, peptic ulcer. Again, large list of additional conditions here. It keeps going on and it keeps going on and on and on. I really just ran out of room on the slide at this point, which is why I didn't keep putting it up. But you know, as you can see from this website, there's a lot of enthusiasm for use of medical cannabis. And you can see someone going to this site would come away with quite an enthusiastic impression that cannabis has quite a widespread use indeed. Now, there is an alternate perspective on the use of medical cannabis, well summarized by this article in the Wall Street Journal by a respirologist titled, "If Weed is Medicine, So is Budweiser." And the main point is in this sentence I've highlighted below. The author is concerned that we don't have strong evidence in many cases that the benefits exceed the harms for use of cannabis to treat different conditions. We do know that it has some effects on judgment and on cognition and driving ability. And if you inhale it, then you take the risk of pulmonary harms to your lungs. So we have two very extreme perspectives out there, one in which cannabis is very effective for a large number of conditions, and the other perspective, which is quite skeptical. So we need to understand more about the actual evidence. But where did we get an initial signal that cannabis might be helpful for the management of certain health conditions? Well, in the United States, a number of individual states have legalized cannabis, either for medical purposes, for recreational purposes, or in some cases, both. And what we've seen in some observational data in some states, not in all, but in some, is that after cannabis became legal to access, there was a reduction in the use of certain prescription medications, in particular medications that were used to treat anxiety, depression, nausea, pain, sleep disorders, and muscle spasticity. So this doesn't tell us that cannabis is effective, but it suggests the possibility that at least some individuals may be substituting cannabis for these prescription medications because they perceive a benefit. When we look at the kinds of conditions that individuals authorized to use cannabis present with as a condition of authorization, this chart, again, from US patients, and I think it's fairly consistent with Canada, really tells the picture quite compellingly. You see that amongst all the conditions out there, chronic pain is by far the most common indication for authorization. It's the reason for about almost 2 out of every 3 authorizations in the US, and it wildly exceeds any other condition. So yes, there are patients in the US that are accessing cannabis for muscle spasms secondary to multiple sclerosis, or for chemotherapy-induced nausea and vomiting, post-traumatic stress disorder, but all of these pale in comparison to the number that are accessing for the purposes of managing their chronic pain. So we've decided to look at this issue by developing a clinical practice guideline. And our clinical question that focused our efforts was in individuals living with chronic pain, either due to cancer or non-cancer causes, should we recommend a trial of medical cannabis or individual cannabinoids versus continued care without medical cannabis? And our recommendation could be strong against if we had good evidence that the harms clearly exceeded the benefit. It could be weak against if we felt we weren't sure, but it looked as if most patients, given the evidence, might decide against. It could be weak in favor if we felt there was a bit of a balance that suggested a little bit more benefit than harms, or it could be strong in favor if we felt the evidence clearly suggested the benefits would exceed any harms. So we use something called the grade approach to guide our efforts. And again, with the grade approach, we can end up making strong recommendations. But to do so, there needs to be a clear imbalance. Either the benefits clearly exceed the harms, or the harms clearly exceed the benefits. We need to be very confident in the evidence underlying that balance. And we need to believe that almost all patients given this information would make the same choice. We could also make a weak recommendation. Now, a weak recommendation is made when there's a close balance between benefits and harms, or when the evidence underlying the benefits and harms is less certain. And if we believe that if patients were given the information about benefits and harms and the underlying evidence, that there would not be a consistent response. Some patients would choose to pursue the therapy and some would not. So that's the context for the approach that we took. Now, we took a patient-centered perspective. We did not take a payer perspective or society. So we looked at the individual patient. We had 21 members on our guideline panel. That included clinical experts, methodologists, and we had 3 patient partners that were living with chronic pain, one of whom had used medical cannabis and found some success, one of whom that had used medical cannabis and found it didn't work for them, and one that had never used medical cannabis. And importantly, no member of our guideline panel had any important financial or intellectual conflicts of interest. And we began the process by trying to understand patient values and preferences. How much pain relief would they require in order to accept some of the risks that we know are associated with cannabis use? So we wanted to understand the relative values or importance of outcomes. Is pain relief most valued? Are they most concerned about addiction, for example? We wanted to understand the values and preferences around different administration routes, whether it's inhaled or ingested or topical, or formulations of medical cannabis for chronic pain. And we wanted to know what factors influence patients' decisions as to whether to try a course of medical cannabis or whether to avoid use of medical cannabis. So we did find 15 studies that had been published in the literature that specifically addressed this topic. All of them were on adult patients, and they typically enrolled patients from the US, but we did have some from other jurisdictions, including one from Canada. They were all very recent, from 2000 onwards, and both cancer and non-cancer patients were represented. So what did we learn? Well, we had moderate to high certainty evidence that many individuals that were using medical cannabis placed value on the effect on their condition, even when they experienced some adverse events related to concentration, memory, or fatigue. We found that there was a greater preference for products that were high in cannabidiol, and this is the non-psychotropic cannabinoid in cannabis. So you do not become euphoric or develop a high with use of CBD. And medical users preferred products that were high in CBD or that had a balanced ratio of CBD to THC versus THC. Now, THC is the cannabinoid that does cause euphoria and has recreational purposes. We found that cannabis use was influenced by both positive and negative social consequences. Cannabis has a long history of an illegal product. It has recreational purposes, and so there are considerations by users. We also found that concerns about medical cannabis included side effects, addiction, tolerance, losing control or acting strangely, and that patients that place greater value on these side effects or avoiding them were much less likely to be interested in a trial of medical cannabis. We found low certainty evidence that there was high variability around the use of medical cannabis or the interest in using medical cannabis amongst people living with chronic pain. And we also found some evidence that some patients were motivated to try medical cannabis as a way to reduce their use of prescription medication, and in particular opioids, which they felt cannabis was likely to be a safer alternative to. Now, we then looked at randomized controlled trials. So what do we know about the evidence for the effectiveness of medical cannabis for chronic pain and side effects that might be seen? Well, we found 32 randomized controlled trials. Most of them looked at chronic non-cancer pain, but 4 looked at chronic cancer pain. They all looked at adult populations. Median age was 54. Length of follow-up, not too long, but it went from a month up to about 140 days. And placebo was the most common control. So not a lot of control against other active treatments. What types of cannabis? Well, most of them were plant-derived cannabinoids or phytocannabinoids. We had 12 synthetic cannabinoids, and 5 of the trials actually looked at the types of cannabinoids that we ourselves make. So we all have very well-developed endocannabinoid systems, and basically the plant-derived cannabis take advantage of receptors that exist in our bodies already to create the effects that they have. Now, what was the mode of administration? Most of them looked at oral tablets. 13 studies looked at oral sprays. 1 looked at drops you place under the tongue. 2 looked at creams, topical preparations. And what was interesting is we actually found no trial that looked at inhaled forms of cannabis. Now, that's interesting because we know a lot of medical users do inhale their medical cannabis products either through smoking or vaporizing. This table is a little bit busy, but you don't need to focus on everything here. I'll explain the first row. So when we looked at the effect that medical cannabis use had on pain versus placebo, we found 27 randomized controlled trials, just shy of 4,000 patients. Follow-up was 1 to 4 months. And the risk difference for achieving an important benefit in pain relief was 10%. So what that means is for every 10 patients that try medical cannabis versus placebo, 1 will experience an important relief in pain. And the certainty of evidence was fairly good. It was moderate. It could be 1 high or up to high, but moderate is usually fairly good. When we look at physical functioning, we also found a significant benefit of medical cannabis versus placebo, but it was smaller. This time, the risk difference is only 4%. That means you have to treat 25 patients with medical cannabis versus placebo for 1 to report an important benefit in physical functioning. In terms of emotional functioning, we found no difference versus placebo. So we did not see an effect on emotional functioning. When we looked at raw physical, these would be things like how you perform at work or around the home. We did not find any difference between medical cannabis or placebo. No difference in social functioning. We did find some improvement in sleep quality. Risk difference of about 6%. Again, it means you have to treat about 17 patients in order to see 1 that will report an important benefit in sleep. So there are some benefits on pain, on function, on sleep, but not for the majority of patients. It's for a minority, but it means some patients do appear to derive an important benefit. What about reducing opioid use? Well, when we looked at the randomized controlled trials, we found 4 that reported on opioid consumption in both the group that received medical cannabis and placebo, and they did not appear to show a difference. But as opposed to the other outcomes I've reported, we rated our certainty in this evidence very low. So this is the lowest quality evidence we can have. Why did we rate it so low? Well, we rated it very low because unfortunately, in all 4 trials that reported on opioid consumption, the investigators instructed the patients not to change their dose of opioids during the trial. So these trials were not designed to look at opioid substitution. So because of the very low certainty, we looked at observational literature, and we did find evidence from 6 observational studies that patients were able to reduce their opioid consumption after they were provided with medical cannabis. But we also graded this evidence very low certainty because it's observational and we're not sure about that effect. So at this point in time, we don't know with any confidence whether or not medical cannabis can facilitate reduction of opioid use. It may or it may not. We need better studies.
Thank you very much, Dr. Busse. Very interesting. We have received a number of questions related to the risk of using medical cannabis. So you touched on it, but could you elaborate a little bit more on the potential risks of using medical cannabis?
Yeah, it's so important. I mean, when we consider any type of therapeutic agent, we have to be given information not only on the benefits, but also on the harms. So we did look at these different types of side effects. We know that most of the side effects associated with cannabis are due to THC, which is the psychotropic cannabinoid, and that they're often dose dependent. The more THC you take, the more you'll notice these side effects. And you'll see a list here about some of the ones that can occur. So how likely are they to occur? Well, we looked at the same randomized controlled trials to get information on this. So you see here, our first adverse event is cognitive impairment. And the risk difference between placebo is 2%. Now that was statistically significant, but what it means is you have to treat 50 patients with medical cannabis versus placebo for one to report troubling cognitive impairment. So it can occur, but it's fairly infrequent. Vomiting can also occur, but you'll see here the risk difference is only 3%. So it's unlikely to occur, but it can. Drowsiness, the same. The one exception is dizziness, where we found people that were using medical cannabis for 3 months or longer. It was about 1 in 3 that at least at some point during their care would report an episode of dizziness. Other adverse events that we found reported in randomized trials were similar. Yes, there was a risk of impaired attention, of diarrhea, of nausea, but you'll see the risk differences were all fairly small once again, between 3 and 5%. So it does mean that it's more likely to happen with use of medical cannabis versus placebo, but it's only likely to occur in a fairly small number of individuals. Now, these are not particularly severe adverse events, and people do want to know about the more serious adverse events. Unfortunately, they're not reported in randomized controlled trials. I think because they're relatively infrequent and the number of patients they enroll in trials tends to be small. So we did go to the observational literature, and we did find a small number of studies that reported on serious risks associated with medical cannabis use, things like developing dependence, road traffic injury, a fall, suicide, or suicidal thoughts. But unfortunately, we had very limited evidence to inform these risks. So all of it we rated very low certainty. We did have quite a bit of information from recreational cannabis use, but we know that's a very different animal than medical use. And so at this point, we're just not very certain about risk of serious adverse events that might be associated with medical cannabis use. Now, I know that there were some questions that were posed before, wondering about what happens to my ability to drive if I'm going to be using cannabis products. And again, we have lots of information about recreational cannabis use, which tells us it's not a good idea. It does tend to impair your cognitive abilities and judgment. We don't have a lot on therapeutic use, but this was a recent study that looked at a controlled dose of cannabis and its effects on driving in simulation studies. And again, what they found was after there had been sort of a standard dose of cannabis that had been taken on, a 100 milligram dose, and they looked at these driving tests compared to people, when they hadn't used cannabis at 1, 3, and 5 hours after inhalation. And what they found was cannabis use showed no effect on simple driving related tasks, but it did show significant impairment on complex tasks, particularly when it was something unusual that you had to do, you might not do during your normal course of driving. And they found that those effects lasted about 5 hours after use. So could cannabis impair driving ability? The answer is, if you are using cannabis products that have THC, there is a great likelihood that it can, maybe not so much with the simple tasks, definitely with the more complex tasks, and it appears to last about 5 hours after intake. Now, if we look back to our recommendation, because we started off wanting to do a clinical practice guideline, we don't want to extrapolate the evidence beyond the populations that were enrolled in the trials that we looked at. So who were the people that were enrolled in these trials? Well, as I said before, patients in the trials we looked at did not explore use of inhaled forms of cannabis. They did not enroll patients involved in palliative care. And therefore, our recommendation is not going to confidently be applied to this mode of administration or to this patient population. And if we look at other limitations of the populations that were enrolled, the trials that enrolled chronic pain patients largely excluded those with concurrent mental illness or those receiving disability benefits. And so the generalizability of our recommendations to these populations is uncertain. We're not sure if use of cannabis, if you have chronic pain and depression, chronic pain and anxiety, chronic pain and PTSD, might show different results than if you have chronic pain without these comorbid conditions. So those are some important limitations. But going back to this GRADE approach that I introduced before, I said there was sort of two types of recommendations we could make. One is a strong recommendation. So given what I've shown, does it make the case that the benefits clearly outweigh the harms, or the harms clearly outweigh the benefits? Probably not. What we're really in a situation of here is when there's a fairly close balance. There is the possibility of benefits for a minority of patients. There's also the possibility of harms for a minority of patients. And so we're coming up to decisions that are more preference sensitive. We do have fairly good evidence, at least for the benefits and some of the less serious harms. Not so sure about the more serious harms. And what we understood from our patient values and preference work and from the evidence we had to look at, it's quite likely that given this information, different patients will make different decisions. And so keeping all that in mind, this was our final recommendation. What we advised, or what our panel decided, was for individuals living with chronic pain who have not found satisfactory relief with their current treatment strategy, they may wish to try a course of non-inhaled medical cannabis. And so we made a weak recommendation in favor of offering such patients a trial. And it doesn't mean it's going to work for everybody, but there might be a minority of patients that will find some benefit. And we believe that they need to be given the information on benefits and harms so that they can make a decision that's consistent with their own values and preferences. And I should state, we've been fortunate to acquire some funding from Health Canada to conduct more comprehensive guidelines on this topic. We are working on those. We anticipate they'll be completed towards the end of this year. And some of the things that we're going to be tackling in these more comprehensive guidelines are getting all the information we can on inhaled forms of cannabis. We know that there's a lot of use of vaporized or smoke forms. We want to be able to answer that kind of issue, so we will look at that more carefully. We're going to update all the prior evidence syntheses that we had done, so we'll have the latest information to guide our recommendations. We want to try to provide information on the relative effectiveness of medical cannabis versus opioids. We know that opioids are commonly used for chronic pain, but individuals are interested in knowing whether or not there's reasonable alternatives out there that might provide similar benefits, perhaps with a lower risk of harms. We're going to do more work on the impact of cannabis on driving. Right now, we have a lot of literature on recreational use and the impacts, but we need to be able to tell people more about what are the typical risks of therapeutic use of cannabis, which does tend to be different than recreational use. And we need to provide both patients and clinicians with information on cannabis tapering. If someone attempts a trial of cannabis, it's not effective, or they find that the harms exceed the benefits and they want to come off it, we have to provide guidance on how that's best likely to be accomplished in a safe manner. And finally, we need to understand more about the risks of developing a cannabis use disorder. This has come up from a number of patients, and we weren't able to inform that in a comprehensive way in the smaller guideline that we did that I showed you. We want to be able to say more about this time around.
Okay, that's great, Dr. Busse. Before we actually get to the next question, we've actually had a number of people just ask for a point of clarification about the research that you were just presenting. And really, it's just a fundamental question. When you're referring to medical cannabis products, are you talking about CBD, THC, or a combination of both? What kind of products are you talking about?
It's a great point. So when we looked at the types of products that were used in the clinical trials to manage chronic pain, for the most part, it was combination products. It was looking at products that had some THC and some CBD. We did find only 2 trials that looked at pure CBD, and these trials were topical preparations. There was some evidence to suggest that those preparations were less effective than combination products, not enough for us to make a conclusive statement. And we don't know whether that potential reduction in effectiveness was due to the fact they were topicals or whether it was because they were pure CBD. The topical preparations of cannabis have a challenge in terms of penetrating your skin. Cannabinoids are quite oily, and so they tend to be resisted by the skin. And so we don't know how well these topical preparations are often delivering the medical cannabis products below the skin where we need them to have an effect. So it's a great question. Most of the trials looked at combination products. In the 2 cases where it was pure CBD, there was some suggestion it might be less effective or even ineffective, but we don't know for sure at this point, and we don't know whether it was because of the nature of the product or because it was a topical.
Okay, thank you so much. That's very helpful. Now to this question. So we always receive many questions about how to access medical cannabis, and tonight is no exception. So could you outline how people can go about accessing medical cannabis safely?
Yeah. So the way that you have to do it is you work with your healthcare provider. Could be a physician, could be a nurse practitioner, and they will prepare a document indicating that you've been authorized to access cannabis for medical purposes, and this is sent to Health Canada, and then you have to fill out a registration document as well. And after it's been approved, you can then place an order online. For example, we have the Ontario Cannabis Store, which can provide, fill such orders and send products to you directly. And, what we know about doing this is there's a number of different places where you can get cannabis products, but there are only certain regulated licensed sellers. So the Ontario Cannabis Store is the only regulated online seller in Ontario. That doesn't mean you can't find other online sellers, but they're not regulated and they aren't under the same sort of guidance that the Ontario Cannabis Store is. So every province will have their own regulated seller. Now, once you have authorization from Health Canada to access cannabis for medical purposes, there are 3 ways in which you can do it. So the one that I've been talking about is buying directly from a federally licensed seller, and each province will have one. But the other thing you can do is register with Health Canada to produce your own cannabis for medical purposes. So you can grow small quantities for personal use, or you can designate someone else to produce cannabis for you. And I put the website here with more information on these different modes of acquiring cannabis for medical purposes. But these are the 3 ways in which you can do it after you've been authorized by Health Canada to acquire cannabis for this use.
Perfect. Okay, so I'm going to switch gears a little bit now and talk about the Cannabis Act. And it's been in the news a fair bit lately. So could you just explain a little bit to us about why it's up for review, why it matters, and how it might affect medical cannabis users?
Yeah. So the Cannabis Act really has 2 objectives. One is to protect the health and safety of Canadians. So there's a lot of new information coming in about cannabis all the time. It was really provided for medical purposes all the way back in 2001, not because we had a clear evidence base, but more on the basis of compassionate grounds. So as we get more evidence, more information, the Act needs to be responsive to that new information. The Act also provides for the establishment of a legal industry to provide people to sell and to acquire cannabis to hopefully move away from the illicit market. So just to give you one example of what the Cannabis Act did, when cannabis was made available for non-medical purposes back in October 2018, they restricted sellers from providing edible forms of cannabis for 1 year. Now, why did they do this? Well, the mechanism of action is different. If you inhale a cannabis product, you will feel the effects usually within minutes. If you ingest a cannabis product, it can take much longer. It can take hours. And so you can well imagine if someone had experience with cannabis in the past and they were acquiring it now that it's legally available, and they acquired edibles and they expected to feel that effect very quickly and they didn't. Well, a reasonable reaction might be to say, I guess there wasn't very much in this, I'm going to take more. And in fact, they found a number of cases where people ended up taking much more cannabis through their edibles than they intended to. Now, you can't fatally overdose on cannabis, but you can take on far too much and have very awful side effects, paranoia, delusions, nausea, vomiting. It's an extremely unpleasant experience. And so because there was concerns that there needed to be more education around the different mechanism of action that edibles had versus inhaled forms, the Cannabis Act said, we are going to make inhaled forms available for the first year, and only after that time and through a lot of education campaigns, we're going to bring edibles onto the market for legal sale. So it is up for revision right now. That's going to be done regularly. And it's really a reaction to want to make the Act reflect the best current available information that we have as we learn more about cannabis and its use and its benefits and its harms.
Great. We are going to address more questions together tonight, but are there particular resources that you would recommend for people who want to learn more about medical cannabis as a potential treatment for arthritis?
Yeah, absolutely. One, I should mention, normally we would just direct people to go to their healthcare provider, their family physician, for information on therapeutic options. There's a challenge with this, and it's been highlighted by a recent study that we published where we interviewed a number of family physicians in Ontario about medical cannabis. And what we found is many of them were reluctant to authorize cannabis for their patients. Why was that? Primarily a lack of knowledge. So medical cannabis is not something that is part of the core medical training. And so if you aren't trained in something, you're going to be less likely to feel comfortable endorsing its use or helping patients to work with it. The good news was that most clinicians were quite interested in continuing medical education on cannabis. And I will tell you that our group received a request from the Ontario Medical Association a little while ago to produce some educational modules on this because it was one of the top rated issues that their members wanted to know more about. They were also concerned about limited evidence. If they were going to authorize cannabis, for what condition should they, for what condition should they not? And there was some concern about potential harms, particularly amongst older patients. Might it encourage a higher risk of falls and consequent fractures? And what about drug interactions? Well, we know there are a large number of drugs that are known to have some interaction with cannabis. Now, out of all those interactions, there's about 27 that could be major. I've put a website link here which indicates some of those where there could be complications. So given the fact that healthcare providers are in many cases sort of learning themselves and catching up with information, what are resources that people that live with chronic pain might go to? Well, I'm going to be a little bit self-serving here. I work with a Center for Medicinal Cannabis Research. I've put the website link up there. We do have a lot of resources that we put out for patients, lay summaries, new research that's appearing. We do have an annual conference that's free to attend that talks about the latest updates and advances in this area. There's also a newsletter that you can sign up for. This is the website. This is a QR code if you're quick with your phones. And we're happy to send you a free newsletter on information related to medical cannabis as well. For those of you that really want to dive deep into this topic, McMaster University has created a number of continuing education courses suitable for both healthcare providers and for patients on the science of cannabis. Now, this is a bit more information than some may want, but if you're curious, you can also look into this. And I should also state that there is a lot of information available on medical cannabis on the Arthritis Society website, where you can learn about a lot of the things I've been talking about today, the difference between CBD and THC, what we know about risks of cannabis use, how to access, and the current research that's developing in these areas. So there are some very good resources out there, and I would encourage you, if you're interested, to look into some of these.
Thank you so much, Dr. Busse. I do want to just ask one question, because I know you focused a lot on chronic pain, and obviously arthritis patients are among those people who experience that. So is there anything that you just talked about that you would say is really specific to arthritis or arthritis patients that you want our audience to know?
Well, it was interesting. Some of the medical cannabis literature that was coming out, especially initially, the guidelines and guidance focused more on neuropathic pain because there was just more studies done on neuropathic pain. Arthritis may involve neuropathic pain, but it may not. What we did as part of our research on this topic, as we explored if there were any differences in benefits or harms based on whether pain was neuropathic or non-neuropathic, including arthritis related, we did not find evidence for a difference. So what I can say is that the results I presented, where there is the possibility of a benefit for a minority of patients on pain, on function, on sleep quality, appear to be equally likely in those suffering from chronic pain due to arthritis as for chronic pain due to other causes. But again, this is a fast-moving area. There are a lot of studies that are ongoing. And I would encourage people that are interested to sort of keep abreast of this, because there's going to be a lot of new information coming out to help further inform these issues.
Before we get into some more live questions that came in tonight, do you have any final thoughts or recommendations for our viewers?
I guess what I would encourage people to consider is, if you are interested in looking at this issue, you do your homework. Work with your healthcare provider. Some are going to be more comfortable on this topic than others, but there is the possibility of drug interaction. So you do want your healthcare provider to be aware of what you're doing. If you do look at embarking on a trial, it typically makes sense to look at starting with these, as I said, non-inhaled products, higher in CBD to start, because we know that you're going to take on less possibility of risks if you avoid products with THC. If there's a partial benefit or no benefit, then you may wish to explore combination products. And there is some guidance out there through expert consensus material that can help your prescriber sort of, look at the kinds of products that you might want to start with and then sort of move forward into if you have partial benefits. But it really should be something that you work on in collaboration with your healthcare provider. And just be aware, there are cases where individuals seem to experience benefits, but it does appear to be not the majority experience. So I think you have to have realistic expectations going into this space.
Great, thank you, Dr. Busse. So I am going to start with a question that's come up from a number of different people. And so I'll just make a generic question here, but many people who are on today's webinar have arthritis, but have many other chronic conditions, whether it's diabetes, heart disease, other things. So are there any concerns around medical cannabis? And you touched on it right now around drug interactions, but what do people need to consider if they're on drugs for arthritis and are considering medical cannabis?
Yeah, so in most of the trials, I want to say all the trials, but let's say most of the trials that we looked at, patients that were living with chronic pain were still allowed to access their usual care. So we did have most patients that were continuing to take things like non-steroidal anti-inflammatory drugs or acetaminophen. So again, these products were tested in sort of typical chronic pain populations. At the same time, they did sort of exclude patients with comorbid mental illness, as I said. So we don't know for sure if the results are going to extend to that group. We do know that medical cannabis and cannabis products are metabolized through something called a cytochrome P450 system. And this is a metabolic pathway through which other prescription drugs are metabolized. And so, as I mentioned on an earlier slide, there have been 27 drugs which they have documented the possibility of a significant drug interaction with medical cannabis products. Blood thinners like warfarin is one that has come up before. So this is exactly why you want to work with your prescriber, your healthcare provider, so that they can give you guidance on whether something or else that you're taking might have the possibility of interacting with a medical cannabis product.
Okay. So a question here, and I'll just tie in two things around longer term use of CBD. And the question here is, can you develop a tolerance to products that have CBD? And can products that have no THC, so only CBD, can they be addictive?
So products without CBD, the latest World Health Organization report has deemed they are not psychoactive, and so they are not addictive. So CBD appears to have a very good safety profile, which is exactly why it makes sense to try products that are high in CBD first if you're interested in seeing if you might get some benefit from medical cannabis products. Can you become addicted to CBD? I think the answer is no. Can you develop a tolerance to it? Less information if it might become less effective over time. The reason I say that is the duration of follow-up on the trials that we looked at was typically only about 4.5 months. So it's difficult to say with great certainty how things would change after longer periods of use. So I'm not quite sure about the tolerance issue and if it might be required to increase the dose to get a same effect over prolonged periods of time. But addiction with CBD does not appear to be a risk.
Okay. So question here about surgery. So can taking medical cannabis before surgery as a pain control option, can that change your surgical outcomes essentially? Does it affect your success in surgery, your pain tolerance afterwards, et cetera?
Yeah, so I don't think that taking on medical cannabis would alter anything about the surgical procedure itself. If you're going for a knee replacement or hip replacement, that's unlikely to be affected. But there has been work done on whether or not individuals that are taking medical cannabis prior to surgery might have greater analgesic requirements, both during surgery and after. We've certainly seen that kind of effect with opioids. So people that are on chronic opioids before surgery typically require more analgesia during and after the procedure because the body has become more tolerant to these agents. So it's an area of active work. There's a possibility that is the case. There's been some case reports, some observational data reported that might support that, but it's a bit of an open question at this point. So it's important to let your surgeon know if you are using medical cannabis so that they're aware of this, so that they're aware of the possibility you might have greater analgesic requirements. But at this point, it's difficult to say with certainty that taking medical cannabis will require you to have more analgesia during and after the procedure.
Okay, so you did touch on how people can access medical cannabis. There is a specific question here about, can pharmacists authorize medical cannabis for use?
Well, so what's interesting now, because cannabis is available for both therapeutic and non-therapeutic reasons, it's very easy to access. Now, I know that Shoppers Drug Mart, for example, has an online portal where they will allow you to order cannabis products for therapeutic use. They will deliver it to you. They'll provide information. I think pharmacists are going to become increasingly involved in providing guidance on this issue. I think they're well positioned to take on that role, actually, if they decide to, because they have so much knowledge and awareness about other medications, possibility for drug interactions. So I do think that pharmacists have a role to play here, and they are going to be getting more involved. And as evidenced by the Shoppers Drug Mart portal for cannabis, we are starting to see it happen.
Okay. Do we know anything about the efficacy of medical cannabis for arthritis based on the type of formulation? So if it's a cream, whether it's something else, do we know anything about that, oils, et cetera?
Yeah. So when we looked at the trials that we have available to us, and we are updating this evidence synthesis, and there has been new information. So we're going to have more information that we'll release, within the next 6 months. But from what we've learned so far, as I said, not a lot of information on inhaled formats. The evidence is coming from ingested, a little bit on topical. Most of these products have been combination products. So they have some amount of THC and some amount of CBD. There's a reason for this. We know that taking CBD can mitigate some of the unwanted consequences of THC. So there's a rationale for the combination product. We also know that they might have different properties. So CBD, for example, at least in lab studies and animal studies, appears to have potentially very good anti-inflammatory properties. So in the trials that have been done, the investigators have largely looked at these combination products. I suspect because they think there might be a bit of a synergistic effect, and there might be, benefits to both these products instead of just one. But at the same time, it's not unreasonable to look at trying something that's pure CBD or high in CBD first to see if it might work for you. And again, where we really sort of run into the challenges is about the bioavailability. So we know that if you inhale a product, fair bit of that is made available to your system. When you ingest a product, it has to go through the digestive system, and there's less of it that's made available to your body to use. And the topicals, they have to get through that aqueous layer of the skin, and we have limited information about how many topicals do a great job with that. So when we see the topicals may or may not be effective, it may be because some of these do a better job of penetrating the skin than others. And we often don't have that kind of information to help guide people when they have all of these topicals to choose from. So we do need better pharmacokinetic data so that individuals that are interested can understand how much of that product is actually going to get through your skin and how much will simply rub off on your clothes.
Okay, question here. Do products need to have THC along with CBD to benefit people for chronic pain control?
Not sure. It's a critical question. So as I said, one of the limitations of the studies we looked at is almost all of the products did contain THC. There were only a couple that did not. And those might have been less effective. The evidence wasn't conclusive enough for us to say, but there was at least a signal that they might have been. But again, is that because they lack THC, or is that because they were topicals that weren't doing a good job of penetrating the skin? Not sure. So this is an urgent area for research to really understand what type of products do you need to take, in what format to get benefit if you are going to achieve benefit. The other thing that's come up is something called the entourage effect. So we've talked a lot today about THC and CBD. These are only two cannabinoids. There are over 100 active cannabinoids in the cannabis plant. And we don't know right now if these individual cannabinoids can work just as well on their own, or do they work better when they're accompanied by other terpenes and other types of agents that you find in the cannabis plant itself. So we've so many questions about this product, and I know that's frustrating to hear from a consumer perspective, because you like to know, tell me what to try, what's going to work for what type of product. But at this point, we have a large number of products available for people. And so unfortunately, there tends to be the need for a little bit of exploration to find out what's going to work, if it's going to work for you at all. And that's why, it seems to be what our experts are telling us. Look at the non-inhaled high CBD products to start. If that doesn't work or doesn't work well enough, move to the combination products to see if you might get a benefit.
Well, you just answered my next question, which was going to be how do people start? So that's great. A few questions here about health insurance, and somebody in particular surprised that they submitted a claim for medical cannabis that was authorized, but it was not actually covered by their health insurer. Could you just comment on that a little bit?
Yeah, it's another area of active debate. So I was at a big annual. It's called the acronym is CLHIA, but it's the Canadian Life and Health Insurance Organization. But it's a big annual conference, and I was there a couple of years ago. And they were asking for presentations on medical cannabis. They wanted to understand, what should we be doing about this? Should we be reimbursing this? And what I heard at that meeting was general enthusiasm to consider it. I think, especially because we're seeing opioid-related adverse events uptick again, in particular during the pandemic, there's a real interest in looking at alternatives. And so what I heard at that conference was enthusiasm, and I'm not going to mention names, but from a number of insurers to consider covering medical cannabis products. But I don't know what individual companies themselves have done. So, I think that there probably are some companies that are covering it. I'll give you one example. Veterans Affairs Canada currently does reimburse their members for use of medical cannabis for management of chronic pain and other disorders. Quite a bit. In fact, last year they reimbursed about $120 million for medical cannabis for Canadian veterans. They're currently reimbursing more for medical cannabis than they are for all prescription drugs combined. So, I mean, they're looking now to see if that policy is something that they want to keep or not. But there are, certain groups that are doing a lot of reimbursement right now, and I anticipate you're going to see insurance companies joining that as well.
Okay, can you travel with medical cannabis across the border?
No, do not. So when you say across the border, I assume you mean into the United States. The United States has sort of a fascinating approach to cannabis. They've got about 35 states plus the District of Columbia, which is legalized medical cannabis. They have around a dozen states that have legalized recreational cannabis. But at the federal level, it is illegal. It is absolutely illegal. So please do not assume that you can cross the border with medical cannabis. There will be consequences, absolutely. Now, again, I anticipate that they're going to deal with this issue in the not too distant future. I know at the midterms right now, which they just had, cannabis was on the ballot in 4 of the states. You're probably going to see increasing numbers legalized. I anticipate they're going to want to do something about it at the federal level. But at this point, it is illegal at a federal level in the United States. You cannot travel across the border with cannabis products.
I'm going to conclude with one question here, which I love, and it's not the kind of question that we normally get. The question is about why did you get into cannabis research, and how do you make sure that all of this important research gets put into practice? How do you work with clinicians and others to make it come to life?
That is a fantastic question, which could go on for a long time, but I will try to be respectful of people's time. I got into it because I am very interested in optimizing management of chronic pain. I mean, chronic pain is just miserable. It really is. It affects every aspect of someone's life. It affects people around us and our families. And the reality is we often don't have great options for chronic pain. And so people embark on these long journeys, trying multiple things, often many disappointments to find something that'll work. Cannabis is something that's out there. We have increasing number of individuals that are trying it. And you saw the numbers I put up on the earlier slide. I mean, it's gone from 24,000 8 years ago to close to 400,000 today. There's a lot of interest, and there needs to be good evidence out there to help guide patients. Should they be interested in this? What type of products? What type of composition? What type of modes of administration? What might it interact with? We need this kind of evidence so that we can provide good information to patients to make evidence-based decisions. So I'm quite keen to get into it for that reason. And I'm entirely agnostic about it. I mean, if the evidence shows it works, I'll report that. If the evidence shows that it has important limitations, I'll report that as well. I have no ties to any financial interest. I hold those stocks. I'm not growing anything, but I think it's important to do research in areas where people are interested and where they're making use, so that we ensure that the evidence and practice are as concordant as possible.
Well, thank you so much for sharing your knowledge with us today, Dr. Busse. We would like to take a few moments to get the audience's feedback on the presentation. So for those of you watching on Zoom, you will see a poll question come up on your screen with some answer options. So click on the response that reflects your thoughts. The statement here is, I feel more knowledgeable and empowered after attending this webinar. We will also be sending you an evaluation form with the recording of this session and the slides. So if you're unable to access that poll question, we'll have the opportunity to get your feedback at that time as well. We really do use that survey feedback to shape future arthritis talks, so we value your input very much. Once again, we are grateful to our partners, Pfizer and United Way Winnipeg, for their support of this event. Keep an eye on your inbox for more information about our next arthritis talks coming up on December 8th about mental health and thriving over the holidays. This concludes Arthritis Talks, Medical Cannabis, What's New and Changing. On behalf of all of us, thank you so much for joining us today, and please stay well.